might start off with introducing our first speaker. And so it's Dr. Emmanuel Novy from the University Hospital of Nancy in France. He's a current visiting student within our group at the antimicrobial optimization group here in Queensland. And he's an intensive care specialist and anesthesiologist at the University Hospital of Nancy, as I said. He's also a PhD student at the University of Lorraine in France. His doctoral thesis is about intra-abdominal candidiasis in the critically ill patient. And his main research themes are centered on antimicrobial optimization in critically ill patients. And he likes to learn more about improving antibiotic, antifungal dosing in conjunction with using therapeutic drug monitoring. He joined our team earlier this year. We're very excited to have him here. He's a very enthusiastic clinician researcher, and I might give him the mic and let him start his presentation.
Thank you, Oz, for this kind introduction, and good morning, everybody. So my name is Emmanuel Novy from France, and I am here for 1 year, as Dr. Melina said, and I will talk about ß-lactam therapeutic drug monitoring in the ICU from an intensivist point of view. First of all, why focusing on ß-lactam? Because ß-lactam are the most prescribed antibiotic as first-line agent in both empirical and directed therapy. Their physicochemical property expose them to a lot of pharmacokinetic and pharmacodynamic alteration in the critically ill patient. And interestingly, there is a gap between guidelines and daily routine practice compared to other antibiotics, such as aminoglycoside or vancomycin, for example. And one of the reasons why there are not so much using is because TDM studies, clinical TDM studies, fail to demonstrate a benefit of the use of TDM to decrease mortality in the ICU patient. Very briefly, we know that antibiotics are exposed to a lot of pharmacokinetic alteration driven by two main mechanisms: change in volume of distribution and change in clearance, especially renal clearance, which lead to a high risk of underdosage for antibiotics. And if we add some extracorporeal support, such as ECMO and renal replacement therapy, that leads to most unpredictable concentration. And which antibiotics are the most exposed to these PK alterations? It has hydrophilic antibiotics, such as ß-lactam. From a pharmacodynamic perspective, we know that ICU patients face bacteria with higher SMIC than non-ICU patients. And when we said higher SMIC, that means that we need to increase our PK/PD target. So there are several reasons to explain this change. But for example, the most advanced are the prior antibiotic exposure. And a couple of years ago, the compact studies report that for different bacteria species, for different type of infection, MIC for carbapenem was quite different between ICU and non-ICU patient. And in ICU patient, MIC was 8 times higher than non-ICU patient. Therefore, is ß-lactam TDM useful? Definitively yes, because of the high occurrence of PK/PD alteration and because both under and overdosage are associated with poor outcomes. But more than useful, TDM is actually recommended. 3 years ago, a panel of experts from the ESIGM published this position paper about TDM of antibiotics in general, and for ß-lactam, they strongly recommended ß-lactam TDM monitoring. But in the same paper, the author precised that at the time of this position paper was published, there was no clinical study which strongly demonstrates the clinical benefit of TDM in the daily routine practice. And we will try to explain why within the next 15 minutes. But before continuing, I would like to highlight the peculiarities of ß-lactam TDM. And for that, we will compare it with aminoglycoside and vancomycin. These two antibiotic class, which has a narrow therapeutic index have a concentration linked with efficacy as well as toxicity, which is well known and well described in the literature. And from a laboratory perspective, immunoassay methods are cheap, are available worldwide, and allowed rapid results. This is sharply opposite to beta-lactam. First, because for beta-lactam, we have two types of concentration, total and unbound concentration. And concentration linked with efficacy or toxicity depends on several factors, such as the type of beta-lactam, the administration method, and the comorbidities of the patient. And from a laboratory perspective, method using to measure beta-lactam concentration require expensive equipment, personal expertise, and consequently, our more center is expert institution. And if we have to summarize the difference between the two antibiotic class, we can say on one hand for aminoglycoside and vancomycin that this TDM is easy to obtain, easy to interpret, and clinical studies have demonstrated a decrease in mortality with its use. And for beta-lactam, it's not available everywhere. It's not easy to interpret, and presently, clinical studies failed to demonstrate a benefit in mortality. And just to illustrate this, we conducted this survey 2 years ago in France, and we asked French intensivists about beta-lactam TDM. And when asked them which PKPD target they were actually using, more than 70% of them response 100% of the time above the MIC, correct, this is a guideline. But during the same survey, we asked them if they know which type of concentration is actually measured in their institution. And very surprisingly, more 70% were not able to say which type of concentration is actually measured. So we can wonder how they actually interpret the TDM results. So let's move to the clinical evidence for beta-lactam. During the year 2022, 4 systematic review and meta-analyses have been published, and we will focus on one of them from Mangalore. These meta-analyses include 11 studies, but you can see that only 4 randomized controlled trials. And we will look at the outcome. For mortality, despite a tendency in favor of the TDM, it was not statistically significant. However, for PKPD target clinical cure or microbiological cure, result was statistically significant in favor of beta-lactam TDM. So based on that, what is your opinion? Are you like some of my French colleagues who said, stop with TDM, it's complicated, it's expensive, and there is no effect, no benefit effect on mortality, so game over for beta-lactam TDM? I tried to be one of them. Yes, but from a pathophysiological perspective, it must be interesting. So first, look at the paper carefully, and strongly recommend to read the paper beyond the abstract, and I will demonstrate why. So as I said, there are 4 randomized control trials, and we will focus on one of them. But before that, how to interpret a TDM study? You have to look at different items, such as type of population, type of PKPD target, for example. But if I can suggest 2 main factors, I suggest to look carefully at the PKPD target because it directly influences the rate of target attainment. And the second one is the outcome, because the outcome influences the sample size, and especially for mortality is very important to look at. So just to illustrate here, we have different population. We have roughly the same PKPD target, and as frequently used, the MIC of Pseudomonas aeruginosa is very often used for PKPD study. So I will focus on the target trial, not because this is an European trial, but because, to my opinion, is the most representative TDM study of general ICU population. So more than 200 patients included, TDM versus no TDM. Please remember the PKPD target. Sorry for the mistake in the presentation because it was for Mac 2 Windows, but you can trust me, the PKPD target was 4 times the MIC of the free fraction based on the ECOF of Pseudomonas aeruginosa, which means 16 milligrams per liter. So 4 times means 64 milligrams per liter. And the primary outcome was a clinical outcome in change in SOFA score between admission and day 10. And just remember that in the end, 65% of infection were documented and the actual MIC was below 4 milligrams per liter. It has a huge importance. So when we look at the clinical outcome, we can observe that for the mortality or change in SOFA score, it was not statistically insignificant. As well for clinical cure, despite being divided by a factor of 2, it was not statistically significant. When we look at the rate of PKPD target attainment, we can be disappointed because even in the TDM group, according to the chosen PKPD target, there was not a lot of patients, which was actually in the therapeutic range. But if we look at the supplementary material, and based on the fact that most of patients have infection with bacteria expressing MIC of 4, all patients were actually in the therapeutic range between 16 and 32 milligrams per liter. And you can also see the very variable distribution of piperacillin concentration. So is this study really negative? I think the answer is open. So how to explain the outcome in the meta-analysis, especially the non-significant decrease in mortality? There was a lot of heterogeneity concerning included population, concerning the PKPD target, as well as algorithm and TDM sample. But once again, if you have to choose two main things, I can suggest the difference of PKPD target, because most of them choose a high PKPD target based on a worst case scenario, which is quite hard to attain. And the second one is the attributable mortality for infection in an ICU patient. It is very hard to say that the mortality is only secondary to the infection by itself, but maybe also for the reason that leads the patient to the ICU, his comorbidity, etc., etc. So based on this new analysis, have you always the same opinion? Game over? Or maybe we can look at other outcomes, such as the clinical cure, but also toxicity. So now maybe it's time to imagine TDM study differently. If we want to continue with mortality, we can suggest some tips, and probably to evaluate only one beta-lactam, to limit the number of confounder in the study, such as dual therapy, such as the type of sepsis or the type of population, because the PKPD target depends on the type of sepsis, especially if there is a source control possible or not. It is the same for the population included. Immunocompromised patients have not the same PKPD target. And I think we need to consider the target attainment very carefully, or to adapt the rate of target attainment before and after bacterial documentation. But I think we can say that this is quite challenging. Please remember that PKPD, beta-lactam TDM in general, is a dynamic process. If you have an intensivist, you already know this type of situation. At the onset of the septic shock, you have a lot of things to do for the resuscitation. And this phase there is a lot of uncertainty. You didn't know the documented bacteria, you didn't know the MIC, and you have a lot of things to do in parallel. But after day 2, if the patient survives, all things change. You start to have an identification, maybe some MIC. And regarding PKPD, your objective will be not the same. And from a PKPD study perspective, most of them focus on the early phase, which is a high demanding phase, where the TDM target is to ensure adequate exposure. So it's mainly based on a worst case scenario, which need a high PKPD target. But there is a few studies that really evaluate the second phase, where we can change our objective of TDM, which could be toxicity, and there is a lot of things to do, especially about the threshold of toxicity. So during the early phase, I also highlighted that if we have changed the definition of sepsis in 2016, it is also because we know that mortality is also driven by the host response to infection. So can we say that the mortality is only dependent of the adequacy of antibiotic therapy? I think no. Even this, that the adequacy remains very important to ensure patient survival. But during the second phase, it has already been demonstrated that the occurrence of inadequate concentration is likely to occur, especially after day 2 in this Belgium study for patients with renal impairment. And there is a lot of area of uncertainty during this second phase. During a long time, ß-lactam have been considered that antibiotics with high therapeutic index, that the antibiotics that are harmless, but we know now that is not true, especially in ICU, and there is a lot of toxic neurologic and renal effect. We have an idea of the threshold, but there is a lot of things to do. For example, for piperacillin, we know that the threshold for neurological toxicity is above 150 milligrams per liter, but we didn't know if it's worse to have 1 or 2 times 300 milligrams of piperacillin or 5 days in a row with 151 milligrams per liter. We didn't know that. So there is a lot of things to do. And for people who think that TDM is cost non-effective, if we are able to demonstrate that with TDM we can decrease toxic level and adverse event, maybe we can decrease the length of stay of our patient, and this could, in the end, decrease the cost of the ICU stay. So if we focus on this phase, we should have economic evaluation, but more studies are needed to definitively conclude. So how conclude this topic? I'm quite convinced that TDM in the ICU remain useful. There is 2 goals, different, but both are important, to my opinion. So TDM goal during the first 2 days are to ensure efficacy. But after day 2, we have to continue to monitor our patient to avoid toxicity. Obviously, the interest of TDM depends on the result delay you have in your institution and your own ability to interpret TDM results. For the future, I think maybe we need to focus on specific ICU populations, such as obese patients, for example. If you read paper about TDM, please read it carefully and go beyond the abstract. Should we really need to demonstrate the utility of TDM? To my modest opinion, I will say no. As an intensivist, I would like to have the ability to monitor each of my therapeutic, such as norepinephrine, for example. We have it for ß-lactam, so why not use it? And for the future of clinical trial, should we really focus on clinical and mortality? I don't think so. And there is a lot of things to do, especially in the second phase after day 2. So thank you very much for your attention and enjoy the rest of the webinar. Thank you.
Emmanuel, thank you for that excellent presentation. What we have with the format today is that we're going to ask the presenters to present each of their talks. And then at the end, we're going to have a question and answer session. So we might leave some of the questions till the end, and we might just move on to the next presentation.